Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm happy to have with me today my partner at Retina Synthesis, Dr. Charles Wykoff of Retina Consultants of Texas, based in Houston, and someone who needs no introduction to those of you who follow clinical trials in the retinal pharmacotherapy space. Today, we're going to talk about a very exciting presentation he gave at the Macular Society on the Wnt signaling pathway and an agonist in that pathway that is very valuable in the treatment of neovascular eye retinal disease. Charlie, the floor is yours.
All right. Good evening, Carmen. Great to be here with you. This is fascinating data, and it really is it's such a privilege to be able to work in clinical trials, over the last many years, and it's particularly rewarding when you see data like this. Like, this is early phase trial data, so you never know where that's going to go, but some really promising signals here, which I think could bring a lot of value to the space. So the title of this is Restoret for the treatment of DME and neovascular AMD, first-time clinical trial results from the Amarone phase 1b/2a clinical trial. Clinical trials never happen in a vacuum. Huge team behind this. Tremendous amount of work went into this from all the investigators and the company EyeBio to get us to where we are. So I'm a consultant for EyeBio. I do research with EyeBio, but I hold no stock or stock options in EyeBio. So the concept here is to try to find a new way to restore the blood-retinal barrier, right? And the concept behind that is that many of our diseases that we're used to managing as retina specialists involve breakdown of the blood-retinal barrier, right? With exudation of protein, lipids, fluid, cells. And here's a few images of those. So here's neovascular AMD, diabetic retinopathy, and retinal venous occlusive disease, which are sort of the three biggies that we manage as retina specialists globally. And the thought here was to go after the Wnt pathway. So let's back up and talk about what the Wnt pathway is. First of all, this is a complex pathway that's heavily involved in multiple biological processes from early cell fate development during the development of humans and mammals, and then also heavily involved throughout the adult life cycle of animals as well. And overall, within the eye, we think that Norrin is a critical diffusible ligand for activation of the Wnt pathway. And Norrin, in other words, Norrin's a ligand that binds around in the sort of extracellular, that diffuses around in the extracellular space and then binds to a transmembrane receptor. But it's not a simple transmembrane receptor. It's a multi-component receptor complex that has multiple components, including Frizzled-4, T-span12, LRP5. Of interest, there's multiple types of frizzled. There's multiple types of LRP5, there's LRP6. There's many different components that can come into this receptor in many different body parts. But in the retina, we think these are the key components. And when Norrin binds to this multi-component receptor complex, it leads to clustering, as shown on the images on the right. And it does this by bringing Frizzled-4, T-span12, and LRP5 all in close proximity. And when that happens, you get then activation of the intracellular side of this complex, and that leads to stabilization of beta-catenin. Normally, beta-catenin is driven for destruction continuously inside of the intracellularly. But when you get activation of this receptor complex, you get stabilization of beta-catenin. Beta-catenin is a transcription factor. So it stabilizes beta-catenin, and then now that it's stabilized inside the cell, it then translocates into the nucleus and leads to transcription of a suite of genes, right? Many different downstream effects here, many of them involved in maintenance of the blood-retinal barrier. And this pathway has been studied now for generations with over 30,000 references to the Wnt pathway in PubMed. So it's a well-explored, complex pathway. And the thought here for many years was to figure out a way to directly activate or agonize this pathway. And the simplest approach there would be, well, just make norrin, right? Just make the norrin protein and inject that into the eye. But it turns out that there's a lot of complexity with doing that. And so a different approach had to be entertained. And that's where Restoret comes into play. And Restoret was an engineered molecule that is essentially a norrin mimetic that works to agonize this pathway or activate it. This is what Restoret looks like. It's also referred to as EY-103. It's tetravalent and it's a tri-specific antibody. So what that means is it's got 4 different binding spots, and 3 of them are unique. So at the top here of the illustration, there's 2 different binding domains, one to one epitope on LRP5 and one to a different epitope on LRP5. On the other end of the molecule are 2 separate binding domains for frizzled 4. And then all of this is joined by a central Fc domain. And the Fc domain has been engineered to be inactive so that it leads to stability of the molecule, but this does not induce an immune response. This is a fully human 200 kilodalton antibody, and then on the right here, it shows what this antibody does. It leads to clustering. The reason it has to be tetravalent is it has to bring LRP5 over to frizzled 4. So it has to create that complex, that transmembrane complex, and it does that and leads to downstream transcriptional activity. And a lot of preclinical work was built in to demonstrating that this antibody led to transcriptional activity of beta-catenin sensitive genes. That's the background to the molecule. So what's the study? So Amarone is a phase 1b/2a trial with 2 parts. Part 1 was an open label, multiple ascending dose or MAD component in which 12 patients were treated with increasing doses of Restoret. Doses were low, 0.05 milligrams, very low dose, up to 0.8 milligrams. Right, and the thought here is that if you have an agonist, you often need much lower doses of a molecule than if you have a blocking agent like we're used to with an anti-VEGF. Very different approach here. So these patients all had either treatment-naive DME or treatment-naive neovascular AMD. The DME patients were treated with Restoret monotherapy. So they were only given Restoret, whereas the wet AMD patients received Restoret plus aflibercept 2 milligrams. All the patients in this study received 3 monthly doses and were then followed through week 12 in a standard ascending dose component of a phase 1b/2a trial. Part 2 was a phase 2a dose-finding randomized component in which 3 doses of Restoret were taken forward and studied in 21 additional eyes, all with treatment-naive DME, again, all given Restoret monotherapy with 3 monthly doses, and again, followed through a week 12. The primary objective here, as you would expect in a phase 1b/2a trial, was to assess safety and tolerability, and then secondary objectives including assessing all of the efficacy endpoints that you would be interested in, including OCT, visual function, and ultimately vascular endpoints as well. So let's look at the result. So these are the characteristics of the patients enrolled. There were 26 patients and 5 patients that had DME and neovascular AMD in the per protocol population. And you can see that their baseline characteristics were typical for this type of a disease population. Visual acuity was 20/63 on average in the DME patients, 21/25 in the neovascular AMD patients, and CST was on average 493 and 523 in the DME and neovascular eyes. So these were overall thick retinas. Here's the disposition and safety outcome. So 31 of 33 patients completed the study, and there were no rescue therapy injections given. And across a total exposure here of 97 Restoret injections given, there were no drug-related SAEs and no drug-related AEs at all, and no evidence of any intraocular inflammation, including no intraocular inflammation called as an adverse event, and then also no clinical exam findings to suggest any intraocular inflammation. So let's now look at the efficacy signals. So this is a clinical case of the very first patient that I enrolled in this trial. This is a patient that was in the 0.48 milligram arm of Restoret, DME, 49-year-old male with 6 months of progressive visual decline. You can see that they had about 20/50 visual acuity and a CST of 517 microns at baseline. Again, treatment naive. I give them one shot of Restoret, and here's what they look like 1 week later. Their CST had improved to 322 microns, essentially normalizing, and they had gained 15 letters of vision. Those visual gains of this patient and anatomic improvements were then maintained with, again, 3 monthly doses through week 12. And the important observation is that this wasn't just one patient. This consistent improvement was observed across these patients with DME. And here is longitudinal change in best corrected visual acuity, both mean and median, and blue and pink trajectories, respectively, over the course of 12 weeks, showing a gain of 7.2 mean letters at week 4, increasing to 9.7 and 11.2 mean letters at weeks 8 and 12. Again, this is all of the DME eyes in the protocol population. Importantly, the means here were not being driven by outliers, as the means and medians are notably similar. And again, no anti-VEGF injections being given here, no need for rescue therapy. And this slide really illustrates why there was no need for rescue therapy, because there was a meaningful and corresponding improvement in the anatomy with Restoret monotherapy. You're seeing, again, the baseline CST value on the far left here, about 500 microns, and then that improves down to 350 mean microns at week 12. So you're seeing a mean improvement of 143 microns with monthly Restoret monotherapy. So we get very granular on this slide. This is all of the patient's CST values at day 1, week 4, week 8, and week 12 with DME. And you'll see, if you look at each of these trajectories, there's a consistent directional anatomic response across the population, where all patients finish with a lower CST than they began, and many have quite marked and dramatic improvements in the CST. Again, this is all with Restoret monotherapy. Of note, though, on the right, there is a spectrum, right? There are still patients with some substantial CST, and the majority down more in the sort of low to mid 300s range, where you would expect them to be after 2 or 3 injections for DME with a drug that gets rid of fluid. So here's a summary of the DME data. Importantly, we saw that all of the doses appeared similarly effective at this stage, given the caveat that it's relatively low numbers of patients in each of these dosing groups. We saw a mean gain of 11.2 letters at week 12, and we saw continued anatomic improvements with sequential monthly Restoret monotherapy injection. And on the bottom right there, you see that there was an 80% reduction in excess CST, as defined as CST over 300 microns by week 12. So here's one more anatomic example with visual acuity from the DME series. This is a patient, 68-year-old female, within the 0.8 milligram dose. You can see they started with about 2080 visual acuity and 840 micron CST, very thick retina. You can see after 4 weeks, 8 weeks, and 12 weeks that there is progressive improvement in both the intraretinal and subretinal fluid compartments, with ultimately a gain of 9 letters there at week 12. So you see dramatic improvement in CST from 840 microns to 308 microns on their trajectory of improvement. And again, this is all with Restoret monotherapy. So pivoting now and looking at the neovascular AMD results that we showed, and, reset here. These patients were treated with combination therapy, as we mentioned before. The DME eyes had monotherapy Restoret. These patients had Restoret plus aflibercept. And the logic here was, this is a phase 1b trial for these patients with neovascular AMD, and we didn't know if this drug was going to have a biological effect. And so we wanted to make sure that these patients were treated adequately with standard of care, which is an anti-VEGF injection, as efficiently as possible for a new diagnosis of wet AMD with vision loss. That's what all these patients got. They got monthly aflibercept. In addition to that, they got Restoret monthly injections as well. Here we saw efficacy at all of the doses, as you would expect. Again, they all were getting concurrent aflibercept. We saw a mean gain of 6.8 letters at week 12. And then from an anatomic perspective, that's where there was a fascinating signal of meaningful improvement in the anatomy from over 500 micron CST, mean CST at baseline, to all patients achieving a CST less than 300 microns at week 4. That can certainly happen in the course of wet AMD, but that consistent improvement across all 5 of these eyes is notable. So in conclusion, this is the data we presented at the Macular Society 2024 from the Amarone phase 1b/2a trial involving 26 eyes with treatment-naive DME and 5 eyes with treatment-naive neovascular AMD from a per protocol perspective. And the key here was to be evaluating a new molecule called Restoret, which is a norrin mimetic and Wnt agonist. And the primary objective here was to assess safety, and critically, there were no safety signals, no evidence at all of any intraocular inflammation, and no rescue therapy injections needed or given. Most interestingly, from an efficacy perspective, we saw fascinating structural and functional improvements that I think were encouraging. This is particularly notable in the monotherapy setting in the context of the DME patients that were treated. And overall, this data suggests that activation of the Wnt pathway may be a valuable approach to treating our exudative retinal diseases. And it's still fascinating to me that this is independent of VEGF inhibitors in these DME eyes treated with monotherapy. So a lot more analyses ongoing currently that need to be looked at from the Amarone data, and then future trial planning to further investigate Restoret are underway. Again, none of this research happens in a vacuum. Huge thank you to the iBio team, all the investigators, and most importantly, the patients for being involved in this program. So thanks, and interested in your thoughts, Carmen.
Well, what was the rationale for doing combination therapy in the neovascular AMD group?
Yeah, a lot of thought went into that. And, you're doing a clinical trial program, especially if it's early phase and you're really not sure about the efficacy of the drug, you want to make sure that patients are well taken care of and that you're not sacrificing patient well-being and outcomes to study a new drug. And there's a fine balance to be struck there for any clinical trial. But the goal here was that we know that anti-VEGF therapy is of paramount importance to start as soon as possible with wet AMD eyes to prevent permanent vision loss. And so the thought is, we don't know if this drug has a real efficacy signal yet before we started this trial. Therefore, we're going to make sure those eyes are well treated and then give them, in addition to that, Restoret. So I think from that portion, those 5 eyes, the main conclusion is there was no evidence of a safety concern for combination therapy. And, larger data sets are going to be needed to see if you can get better outcomes there with combination therapy than with anti-VEGF monotherapy.
So retinal vascular permeability is the primary driving force in diabetic retinopathy, less so in neovascular AMD. So do you think that Restoret will be useful as a monotherapy agent in neovascular AMD?
It's a good question. And I think the short answer to that is we have a lot to learn. If you look at some of the preclinical work with Wnt agonism, and there's some other molecules that have been created very similar to Restoret that lead to clustering and activation of the Wnt pathway in models of eye diseases. For example, the OIR model, the ocular ischemic retinopathy model in animals. And what we've seen there in some of the preclinical work is that Restoret can actually normalize and maybe even improve blood flow. You can take areas of ischemia and or non-perfusion and get potentially reperfusion of those areas. So in diabetic retinopathy, that's obvious. Could we cause reperfusion of damaged retina? Maybe with this drug, and that's being looked at in the patients that have been treated so far, and I have no data on that yet. In AMD, could there be a disease modification that Restoret could achieve? For example, maybe AMD is at least partially caused by choriocapillaris or choroidal ischemia, and could there be some normalization of blood flow in that tissue that would somehow decrease the drive of AMD? I don't know the answer to that, but I think that there is a fascinating pathway, it's a complex pathway, and there's a lot of work to be done to try to see how this pathway may be differentiated from anti-VEGF monotherapy.
So what are the next steps?
First of all, this is an ongoing trial, Amarone. There are some patients that are receiving 6 monthly doses, and so far this is data from patients receiving a total of 3 monthly doses. There'll be more efficacy and safety data to come out. Many other endpoints are also being evaluated in this trial, including angiography analyses, which could be fascinating. So additional analyses of the ongoing data set, and then trying to think about what the next steps could be for moving forward for additional trials that are controlled, right? To have a control arm where you're comparing it to the current standard of care clinically, which is anti-VEGF monotherapy.
So if we look 10 years in the future, the world of retinal pharmacotherapy is going to be motivated by disease pathways that are totally foreign to us now. The VEGF pathway was added to with the Ang2 pathway, and now we're looking at the Wnt pathway, and this is indeed extremely exciting.
I agree. It's super exciting for the field to see a new pathway have such dramatic visual and functional benefits. Again, we always need to be cautious. There's only a handful of patients here, but it's more than 5 or 10. There's over 30 patients treated here. No safety signal, meaningful biological response. So we'll see what additional data brings. But I think right now we can say very exciting and holds a lot of promise for patients.
Charlie, thank you for joining us tonight on Retina Synthesis. Have a good time.
Thanks, Carmen.